For a patient with high-risk cytogenetics, which we define as importantly deletion 17p, but the percentage matters, and I'll get back to that, translocation 414, translocation 1416, and while not considered true high risk, the amplification of chromosome 1, because now we consider standard risk the absence of chromosome 1 amplification. So the management of these patients, and I wanted to mention specifically, 17p deletion is very important to talk about specifically because we know that both clonal burden and allele burden matters. What does that mean? Having a few cells with deletion 17p is not necessarily high risk, and we're talking about FISH that's done with CD138 selection or SIG-FISH, and depending on the studies, at least 20% to perhaps 60% a deletion is considered high risk. Small numbers may not be. But let's just put the semantics aside and say the patient has standard high risk myeloma. Induction therapy, perhaps carfilzomib, Lendex, and perhaps quadruplet. But transplant consolidation is reasonable, although we still haven't improved outcomes of high risk. And I think one area where we may tweak the maintenance of high risk patients is with not just lenalidomide, but perhaps dual therapy. The Emory group did a retrospective study showing that combination maintenance therapy with a proteasome inhibitor seemed to improve the outcomes of these patients. And so either bortezomib or off-label use of ixazomib might be something to consider. And in particular, I think a PI or proteasome inhibitor might be prudent to use in a patient with 414 translocation, which has been better overcome or addressed with proteasome inhibition. This patient elected to do maintenance therapy, and I do recommend maintenance therapy in all my patients. I think everything we talk to about patients should be a risk-benefit. And so lenalidomide maintenance in both the CALGB and IFM studies published in the same New England Journal showed that PFS of non-maintenance patients is essentially approximately 2 years post-transplant. With the addition of lenalidomide, that doubles to nearly 4 years. Both those regimens used lenalidomide 10 milligrams continuously. And one of the trade-offs, though, is that this additional PFS came at the expense of secondary primary malignancies. So both studies showed that the control arm, which got placebo maintenance, had a 3 to 4% risk of SPMs, and the addition of len maintenance doubled that to 6 to 8%. So I do recommend for all patients going through maintenance on lenalidomide to keep up with their age-appropriate cancer screening, mammograms, colonoscopies, skin exams, because the tumors that were developing in these patients were of all types, solid, liquid. So it's important to pay attention for the blood counts as well. So I think len maintenance, with that discussion of risk-benefit, is evidence-based medicine and increases PFS. The one thing I do a little differently is I don't do 10 milligrams continuously. I think it's nice to give patients that week off. And I think it lets the bone marrow recover a little bit. I've seen less fatigue. In my experience, I haven't seen very many secondary malignancies either, so that's something to consider. But the initial studies, as mentioned, did it continuously.